Okay, we're live, I think.
Yeah. Good afternoon, WebShadowers. Welcome to week 3. We would like to thank you all for attending our session today.
Wait, are we?
Yeah.
I can't see it
Oh,
live.
no, wait, I don't think.
Yeah. Mine says meeting is
Oh,
now
yeah.
streaming.
Oh, here we go. Yeah.
Okay, now it is.
Should I start over?
Sorry.
No worries. Good afternoon, WebShadowers. Welcome to week 3. We would like to thank you all for attending our session today. Today, we have the pleasure of hosting Dr. Manjaly, an ENT surgeon from the UK.
As always, please remember that the Google form will be posted in the comments in our Instagram bio at the end. With that being said, Dr. Manjaly, you may start whenever you're ready.
Super. Great. Well, thanks everyone for having me on, and feel free to let me know any questions as we go along. I've got half an eye on the chat. Great. So this talk is going to be on ENT emergencies. I am a consultant ENT surgeon in the UK. I'm reliably informed that consultant is kind of the equivalent of attending in the US. And I specialize in ear and hearing problems for adults and children, so all ages from babies to the very elderly. And that includes auditory implant surgery, and I'm based at the Royal National ENT Hospital in central London. I run an Instagram, which is sort of, I put it full of stuff geared towards medical students, career stuff and ENT stuff. So feel free to check that out. And that's how Erin and Isis invited me on today. So thanks for having me. So let's get cracking. I'm going to start with a scenario. I'll play a little video, which is from a British drama from a few years ago. You've got a 30-year-old male presenting to the emergency department with a bleeding nose, and he has haemophilia. Which of these options does not have a place in managing nasal bleeding? So it doesn't matter if you get it wrong, just have a go at answering in the chat. I will keep an eye and then we'll move on. There's a bit of a delay between your answers and me seeing them. So I'll just wait a little bit and let you have a go. Okay. Give you till the end of the video and then we'll talk about it. This talk was going to be earlier in the day until I realized that that would involve people in California waking up at 6 a.m. and I wouldn't wish that on any of you. So I hope this time is a bit more convenient for everyone. So most people are saying E. That is not the correct answer, but I'll explain why. It's not surprising that most people said E. We'll wait till the end of the video. Okay, good. So let's move on. So nosebleeds are otherwise known as epistaxis, and it's a really common ENT emergency. You probably all had a nosebleed, and it's obviously something that happens to all your friends. And at the very severe end of the spectrum, it can be fatal. So it needs the respect that it deserves. And if I was to ask you, what would you advise your friend who's got a nosebleed? I'm sure that everyone would kind of hold their nose in different positions. Particularly in the UK, I know that lots of incorrect advice is given there, even from medical professionals. So the correct way is to pinch the soft part of your nose and sit in a neutral position for 20 minutes. That's the first thing to do. So the answer in the previous question is C, because you shouldn't pinch the bony nasal bridge. That's not going to do anything. When nosebleed epistaxis is severe, then you need to manage it in a hospital setting. Obviously, PPE is in vogue at the moment, but I've been telling people to wear PPE for years because obviously blood coming from the nose just gets everywhere. So you need to wear eye protection, mouth protection, and put some scrubs on. I've had enough shirts ruined by bleeding noses. Now, we don't take long histories in ENT, but you want to get a quick idea of how much blood has been lost. And you want to get an idea for which side it's bleeding from. If it's one-sided bleeding, that will usually give you an idea that the bleeding is coming from the anterior part of the nose. If there's a lot of blood coming out of the mouth, that's usually a clue that the bleeding is coming from the posterior part of the nose, and that influences how you manage it. You want to get an idea for any medical problems that will influence whether you admit the patient and also whether they need to be corrected, such as high blood pressure, and any offending medications that might be causing this. And you also want to get an idea for if you were to stop the bleeding, can they go home the same day? Obviously, in a very severe bleed, the usual resuscitation guidelines apply. So making sure their airway is clear, making sure they're oxygenated, and replacing any fluid loss. So that involves checking the heart rate and blood pressure, and giving IV fluids, getting a group and save and maybe a cross match, and making sure that they're hemodynamically managed. And then in terms of stopping bleeding from the nose, there is a stepwise ladder, starting from very simple things onto more invasive things that are more effective. So the first thing is using these thudicum speculum to look inside the nose with a headlight and see if you can use suction and figure out where the bleeding is coming from. Then you use this spray, which is called cophenylcaine. That's a mixture of lidocaine and phenylephrine to numb the nose and vasoconstrict to stem the bleeding. And that helps you to kind of deal with the problem without the patient being too uncomfortable. The first step is this called silver nitrate cautery. So you touch it on the nasal septum, and it induces a chemical burn to stop the bleeding, and that will usually solve the problem most of the time. If that doesn't work, then the next stage is packing, and we have different ways to pack the nose. And in this picture, in the bottom picture, you see something called a Miracell tampon being used, and that essentially is inserted into the nasal cavity, and then it swells up to tamponade the nasal cavity and stop the bleeding. The one above is called a rapid rhino, works very similarly, but you put it in the nose and inflate it, and again it stops the bleeding. Now, the key thing here is that you want to insert the tampon at 90 degrees to the face. The mistake is to kind of push it upwards, and then it gets stuck around here, and the whole thing just appears like a tusk. So you want to really push it parallel to the nose so that it goes all the way in. So as you can see, the nasal cavity is shaped as such. Okay. If that doesn't work, then the next stage is to use BIP, which is a short form for bismuth iodoform paraffin paste. So that's essentially a yellow gungy ribbon that has hemostatic properties, and you use these Tilly's nasal dressing forceps to insert the packing into the nose. Rather like this badly drawn diagram. So the idea of this being that you want to put your first thread all the way to the back. You don't want your pack bunching up here if the bleeding is coming from here. Now that should usually stop most bleeds. But if that doesn't work and the bleeding is coming from the back of the nose, then we use a urinary catheter, which is kind of not something you'd expect to use. But essentially you can feed it into the nose like a nasogastric tube and look through the mouth until the tip appears at the back of the throat. You then pull it back slightly and inflate, and that will tamponade the back of the nose, and then you can pack the front of the nose with some of the other methods that I showed before. So that's the kind of situation I'm referring to. So you then want to clamp the front of the tube with an umbilical clamp, and you want to put some protective gauze around here to stop the clamp from pressing on the alar cartilage of the nasal cavity. because that can cause necrosis. So you really want to be careful to do that. Good, okay. If all that fails, then the next step is to operate. And we have different ways of stopping bleeding surgically. The first stage being simply to have a look in the nose with a camera and buzz any bleeding vessels. But the most effective way usually is to perform a sphenopalatine artery ligation. And that is done endoscopically. There's a way of finding it, and like in this picture, and you essentially identify the vessel and either clip it or burn it. And that usually will stop most severe bleeds. In the very extreme cases, you can tie off the external carotid, but that's really a life-saving measure. If you give the nose a good spray before you do anything with anesthetic, then it makes it much more tolerable. So it shouldn't be too painful, but obviously it's not the most comfortable thing. Okay, good. Time for another question. Here we've got a 1-year-old child who presents with unilateral brown nasal discharge. I appreciate the picture, it's not very brown, but just imagine that it's brown. No eye signs, hemodynamically normal, but won't really let you examine things properly. So I'm just going to let you have a look at that and tell me what you think you would do next. And I know that there's a delay, so I will pause and perhaps have a look at the chat questions whilst you're having a think. Yeah, this talk will be about an hour. And yeah, it's very similar to actually having a COVID swab done, instrumenting the nose. So yeah, that's a good question. And yes, my accent. Yes, I hope I hope that you're able to all understand and enjoy it. Okay, good. I'll give you a bit of time to answer. So a mixture of A and E. I'll give you a little bit longer. Okay, so mainly A and E, but a whole mixture. Okay, right, let's move on. So this is a case that I had when I was a junior, a young child that came in with a mucky nasal discharge, and the emergency department phoned me and said, can you take a look at this child and maybe bring him back to clinic? And in a unilateral nasal discharge in a child, the first thing you should always think of is a foreign body. That's the first thing you should think of. So obviously the next thing was to ask, could he have put anything in his nose? He wouldn't let me look at him. He wouldn't admit to putting anything in his nose. His mum thought that there might be a red bead that one of his siblings mentioned, but the history was unclear. So on that basis, I made a plan to bring him back the next day for a short general anesthetic where we would just examine the nose and make sure there's nothing there. But just as he was leaving, I asked the question, is there any chance this could be a button battery? Because that is something that needs removing urgently. And they weren't sure, they weren't particularly suggestive that it could be a battery, but I said, well, let's get an X-ray just in case. And lo and behold, the X-ray shows a button battery, that double halo sign. So this was a really memorable learning point. There was no suggestion that there was a battery in the nose, but it was purely on the X-ray that we found it. And I was told off by one of the staff for exposing a child to radiation before going with this X-ray. But actually, it was the right thing to do. So basically, the learning point there is, if the history is not clear, get an X-ray, rule out a battery. And we went straight to theatre within the hour and got it out. Because if you leave a battery touching a wet mucosal surface, it will erode everything in its wake. So even within that day, that child developed a septal perforation. but swallowed unidentified button batteries in children have killed children. So don't ever forget that. Obviously, most foreign bodies are in children, and children love putting things in their orifices. And ENT, one of the most common things as an ENT junior is being asked to remove them. So here's my advice for nasal foreign bodies. If you are working in the emergency department and you are not confident that you can get it out, it's better to refer to ENT, because ENT will have the skills and the tools to do it. And you really get one good shot with children. Once you upset them, they're going to kick and scream, and they're never going to let you try again. So it's better to it's better to have one good go. And the art is to get behind the foreign body and hook it forward. If you try and pick at it with some forceps, you generally just push it further in. So always get behind it and drag it towards you. Good. Okay, that's probably all I need to say on that. Foreign bodies in ears, same sort of thing. Try and use a microscope. Try and get behind the foreign body and drag it towards you. And you know, children love putting beads and sweets and sweet corn and all that in their nose and ears. So it's a very common thing. The answer to the question was lateral X-ray, which I think was option C. Good. So if you can't get it out, then you need a short general anesthetic in children. Now, sometimes insects can get in the ear. I've had stories of spiders in the ear, and it's best to drown the insect with olive oil before you remove it, because it can sting on the way out. So I remember one case where I advised someone to put olive oil in the ear, and the spider just rose with the olive oil and then scuttled across the patient's face and off into the resuscitation area. But generally that's better than having it upset and sting. So good. Okay, now foreign bodies in throat. The most common thing we see in children is coins. So now I've got a 13-month-old baby who is quietly sleeping. Let's hope he doesn't wake up. But they love putting things in their mouth. That's what they do. And if they swallow it, it will usually get stuck at the upper esophagus. So when you've got a foreign body in throat, you want to first assess, is the patient in respiratory distress? If they're struggling to breathe, then you want to clear their airway. Most of the time, if they're stable, it will be in the esophagus. So you want to take a good history. What is the foreign body? What exactly happened? Examine the patient and use investigations like X-ray, lateral and AP, and create an index of suspicion. And it's the index of suspicion that leads you to plan the management from there. So if it's a sharp or a metal foreign body, then it needs to come out. If it's a soft food bolus, you might wait a little bit, give them some Buscopan, and see whether it clears on its own. So a lot in adults, this will often be an issue with bones. So chicken and lamb bones can be quite dangerous. Fish bones, less so, but still, if you identify a fish bone by putting a camera down through the nose, flexible nasendoscopy, then it needs to come out. Not all fish bones show up on X-ray. So always remember that, you know, if fish and chips is mainly an English thing, isn't it? So I don't know how much of a thing it is in the US, but you know, I always tell my students, if they've had a standard chip shop fish like cod or haddock, that will usually show up on X-ray, whereas a posh herring or kipper bone doesn't always show up on X-ray. So that's how I remember it anyway. Good. Okay. So soft foreign bodies that are not causing airway obstruction, can treat it conservatively overnight. Anything sharp or batteries needs to be removed urgently. Good. Okay. This is just to show that X-rays can be difficult. So in the middle of the night, you know, you may not have a radiologist around to report it. If you look at this X-ray here, all this stuff is ossified cartilage, and actually the foreign body is much more subtly found in the esophagus. So index of suspicion is important. The history and the examination is important. Right, let's move on to ears, which is obviously my area of specialty. Common ear infections. So this is obviously your ear anatomy, which I won't spend too much time because I know you had a recent talk on that. Now, in adults, the most common ear infection is otitis externa. So you look in the ear and the ear is red and swollen and full of this debris, and the patient is complaining of pain and discharge in their ear. So that is otitis externa. And the way to treat that is with drops, so antibiotic steroid mixture drops. So in the UK, we have Sofradex and Gentasone HC. They're a mixture of antibiotic and steroid. That's the most effective way of treating otitis externa. If the ear gets so full of gunk, so an infected ear will produce debris. And if it gets too full of debris, then those drops aren't going to work. So you're going to need to perform microsuction to clean the ear and then start using the drops. So that's the way to do it, and advise the patient to avoid getting any water in the ear. Good, so that's microsuction. If the ear canal gets so narrow that the drops aren't getting in, you can use something called a Pope wick, which is basically a tampon for the ear canal. You slide it in, add the drops, that will then swell up and get the drops to where they need to get to. And you can usually remove it after 3 or 4 days and then carry on with the treatment. Necrotizing otitis externa. So this is kind of something you don't want to miss. So think about this condition in a patient who has otitis externa that's not getting better, that's causing night pain. You look in the ear and they might have some granulations, but think about it in the patient who's immunocompromised. So patients who are diabetic or who are on chemotherapy, those are the patients that get this. And essentially it's a skull base osteomyelitis that presents as an external ear infection. And that in that scenario, you've got infection in the bone and it can lead to death untreated. So in the late stages, it can cause brain abscesses, meningitis. It can knock out some of the cranial nerves, so give you a facial palsy and a vocal cord palsy. And so you want to, that patient needs to be admitted and started on intravenous antibiotics for an extended period of time, usually several weeks and months to get it clear. So a CT scan will help make the diagnosis. Blood tests will also be informative. And in the UK, certainly we manage these patients in combination with the microbiology and infectious diseases teams. Diabetic patients need to have their sugars controlled. And if they've got vocal cord palsy, you'd involve speech and language therapy. If they've got a facial palsy and can't close their eye, you might want to involve ophthalmology and physiotherapy. Okay, good. What's going on here? So, acute otitis media. This is most common in children, the most common infection you get in children. It's very common, child complaining of an earache, or if they can't speak, tugging at their ear, restless, poor feeding. Now, most of the time, this is caused by a virus. And so good analgesia alone is appropriate, and it wouldn't make sense to give antibiotics in every case. But there are some cases that it's important to give antibiotics because left untreated, this can lead to significant complications. In the UK, we have quite clear guidelines. I imagine they're pretty similar in the US, but any child under 2 needs to be started with antibiotics straight away. If both ears are affected, start antibiotics straight away. Any symptoms of local complications, so facial weakness, dizziness, visual change, neck swelling, antibiotics straight away. Or if the problem is recurring, or if it's not got better after 3 days. So those are your reasons to give antibiotics straight away for acute otitis media. And as you can see, the eardrum, the tympanic membrane is bulging, and that is usually a good sign of the condition. So as I said, if you leave this untreated, it can cause complications. This child has got mastoiditis, so the pinna is pushed out, and there is redness and swelling and usually tenderness behind the ear and loss of the post-oral sulcus. At this stage, you definitely need to admit the child and give them intravenous antibiotics. If there's a really fluctuant bulge, then they're going to need surgery. But you would always get a CT scan before you go to theatre, to the operating room, because you want to make sure that there's no brain abscess before you go and do an operation on the ear. Okay, good. So take a look at this audiogram. Again, not expecting you to necessarily all know the answers, but take a look and tell me what you think is the most accurate interpretation of this audiogram. The YouTube's a little bit behind, so I will pause there and let you answer. I'll answer some of the questions in the meantime. So pressure on the ear during sleeping causing rupture? Not usually, no, that wouldn't necessarily cause it. Okay, the answers are coming through, a whole mixture of answers. Okay, so interestingly, not many people actually getting the correct answer, which is fine, but I'll talk you through it. Okay, so take a look at this diagram again. When we hear sound travels into the ear canal, it hits the tympanic membrane. That in turn vibrates the three ossicles, the malleus, the incus, and the stapes. And the stapes connects with the inner ear, which converts the vibrations into electrical impulses to the brain. If there is a conductive hearing loss, then that means that there's going to be a problem from somewhere from the outside up until the stapes. If there is a sensory neural hearing loss, then the problem is going to be in the cochlea or the nerve or the brain. And if it's a mixed hearing loss, then both things are going to be responsible. So obviously this is a whole lecture in itself, but if you look at this diagram, the X's refer to left-sided air conduction, okay? And any circles would refer to right-sided air conduction. And the bone conduction is mapped by these little ear-like projections. And imagine that you're looking at the patient. So this ear would be the left ear as you look at them. So that is left-sided bone conduction. Bone conduction is something we use as a surrogate marker for inner ear function. So it's a way of testing the inner ear regardless of how good or bad the middle and the outer ear are functioning. So that's why it's important. So if you know, and so on an audiogram, hearing is tested at various different frequencies, from low frequency to high frequency. And the lower down you go, the louder the sound needs to be played for you to hear it. So 20 decibels and below is abnormal. So as you can see here, the left-sided bone conduction is in the normal territory. So we know that the inner ear is working fine, but the natural hearing, the air conduction, has a problem. Therefore, you can conclude that there must be a problem somewhere along the line in the outer ear or the middle ear. And that's how you conclude that it's a conductive hearing loss. So if there's a gap between the two lines, it's a conductive hearing loss. If both lines have a gap but are both below 20 decibels, then it's a mixed hearing loss, i.e. they both have a problem, okay? So if the lines are at the same, then you know that the air conduction is working as well as it can, but the problem is with the inner ear, and that's a sensory neural hearing loss. Okay, I hope that makes sense. I've got a question in the group, in the chat. Are late-stage symptoms reversible for necrotizing otitis externa? Yes. So necrotizing otitis externa is a treatable condition. Does cold weather cause ear infections in adults? Not on its own, but we know that viruses and bacteria tend to thrive more in cold weather, and that's why we see children have more otitis media in the wintertime. Okay, good. So understanding between, when someone loses their hearing, understanding between sensory neural hearing and conductive hearing loss is important. The way, if you don't have the benefit of a pure tone audiogram, then you can use tuning forks and use Rinne and Weber testing to figure out, to give some clue whether a hearing loss is conductive or sensory neural. And I know that this has been covered in one of your previous lectures. But if you have sudden sensory neural hearing loss, then you treat that as an emergency. So they need a hearing test the next working day. You should give them high dose steroids for a week, and then think about an intratympanic steroid injection. So that means injecting steroids through the eardrum to bathe the inner ear in steroids and try your best to reverse the hearing loss. That's the best available treatment we have at the moment. It's not always successful, but that is the best option we have at the moment. Okay, good. There's a question about inserting tubes in ears of children with infections. Yes, so grommet surgery, or ventilation tubes as you call them there, is a way of treating recurrent acute otitis media. Usually you'd only resort to that if a child is having 5 or so episodes in 1 year, and you might also try a low dose prophylactic course of antibiotics as an alternative. Okay, good. So what is wrong with this guy? Spot diagnosis. I'll just give you a minute to come up with the answers. It's not a trick question. Fractured nose. So actually, if you type in fractured nose into Google, this guy comes up. So he's probably the most famous broken nose on the internet. I don't know if you knew that when he was having this picture taken. But essentially, you don't need to rely on imaging to diagnose a broken nose. The most important thing is 2 things. You want to look and see if there's any midline shift, as there is in this case. You can see that the nasal dorsum is deviated to the left, and you want to exclude a septal haematoma. So the way you do that is to look inside the nose and see if there's any bilateral boggy swelling. If there is a septal haematoma, it needs to be drained straight away. Now, as long as there's no septal haematoma, you generally would wait for the swelling to go down and then reassess. And there is a procedure that can be done called a manipulation under anesthetic, where you essentially short anesthetic and just crunch the bones back into place. That is effective for when the nose has shifted from the midline. So it's not going to correct any sideways view humps or anything like that. It's purely in the early stages when the swelling has gone down, but the bones have not quite refused. So that's the 2-week window is the best time to do that. Okay, so within 14 days. This is what a septal haematoma looks like. If you're not sure, you can use a little probe to just prod it, and if it feels boggy, then that needs draining in theatre, in the operating room. Okay, right, question for you. I'll wait for YouTube to catch up. How are we doing for time? Okay, we're doing well. I'm absolutely amazed that 690 students have logged on for this. So, so thank you. I hope it's been useful so far. And like I said, I put a lot of this kind of stuff on my Instagram, so have a look at that. Good. Okay, there are enough C's, so I'll carry on. I take that as an encouraging answer. Okay, good. So patient comes and says, I've had a sore throat for a few days. What is the diagnosis? Fire it in the chat. What is the diagnosis here? It's obviously tonsillitis, okay? And basically the rule is if the patient cannot eat and drink, then you need to bring them into hospital and give them intravenous fluids and intravenous antibiotics. You want to avoid anything containing amoxicillin, because if they've got glandular fever, then that's going to give them a rash. So in the UK, we tend to go for benzyl penicillin and metronidazole, IV fluids, analgesia, and some steroid, and that will usually make them feel better quite quickly. And once they've started eating and drinking, then you can convert them to an oral option and send them home. It's usually useful to get a monospot test to rule out glandular fever. And the treatment is very much the same. The only thing is that if you make a diagnosis of glandular fever secondary to Epstein-Barr virus, then you need to warn the patients to avoid any contact sports for 3 months, because you can get splenomegaly in Epstein-Barr virus, and any trauma to the spleen can cause splenic rupture and a very dangerous intra-abdominal bleed. So that's why it's important to diagnose. And you think about it in young people, often university students who are mixing with lots of different people, so that and who are often sleep deprived. So that's the kind of category we tend to think about. Okay, good. So that's tonsillitis. Now, if you look at this picture, people sometimes wonder what's the difference between tonsillitis and a quinsy. Look for the asymmetry. So look for uvular shifting. So the uvula is that little punch bag at the back of the throat. If it's deviated to one side, that is where you want to think about a quinsy. So it presents similarly, but often you get trismus, which is difficulty with mouth opening. And in that case, you know that there is a collection of pus next to the tonsil, which is going to need draining in order for this to get better. And if you leave it, it can lead to parapharyngeal abscesses and airway obstruction. So it's not something you want to be missing. You can drain a quinsy with the patient awake in theatre. Obviously, PPE, spray the throat with anesthetic, and you want to stick a needle into that space, just parallel to the tonsil. Hopefully, you'll draw back pus. And then the gold standard is to then open up that space with a blade and with some forceps. Now, people worry about sticking a needle in someone's throat. Actually, you can cut the plastic guard and to 2 centimeters and put it back on the needle, so that only 2 centimeters is exposed. And usually that will stop you from going anywhere near the carotid artery. If you really want to be extra sure. But as long as you go straight and not sideways, you're going to be fine. And that's something that our, the most junior member of the ENT team would do. Okay, good. Tonsillectomy. So tonsillectomy is an operation that we do a lot of in ENT, or at least as a specialty we do. I'm more specialized in ears nowadays. We know that however well tonsillectomy goes, there is a risk of bleeding in the first 2 weeks, what we call a secondary hemorrhage. And that rate lies somewhere between 1% and 5% or more, depending on what you read. If anyone comes back to the hospital with some history of bleeding after having a tonsillectomy, always keep them in hospital, even if the bleeding has stopped, because a small bleed might be what's called a herald bleed, where it's a clue that a bigger bleed is on the way. So always bring them in for 24 hours of observation, intravenous antibiotics and fluids, and make sure that there's no further bleed. Always notify the ENT seniors that you've got a patient in like this. If the throat has stopped bleeding, then you can admit and observe. If there's any active bleeding, then they're going to need the operating theatre. And particularly with kids, they haven't got as much blood to lose, so you need to crack on. Whilst you're waiting for the operating room, you can give them hydrogen peroxide gargles to gargle on, ice in the mouth, and as a severe step before theatre, you can shove some adrenaline, or you call it epinephrine over there, swabs in the tonsillar fossa. Okay, good. So that basically just summarizes what I've said. Okay, good. I'll just check the chat. Any key questions? I think Erin and Isis are going to put on the chat. And Erin had a secondary hemorrhage. Goodness. So there you go. I bet there are more people on this group that have had that as well. So why is it called a Quinsy? Who knows? I mean, it's just a weird name, isn't it? Peritonsillar abscess is the proper name. Colloquially, it's called a Quinsy. Okay, stridor. What is stridor? Stridor is a high-pitched inspiratory noise that sounds a bit like this. Now that is very different to stertor, which is the kind of gurgly, snory sound that you will hear when someone falls asleep on the plane next to you. Okay, so stridor and stertor, two different things. Stridor indicates that the airway is at risk. So that's what you need to know. Stridor, you hear stridor, you think the airway is at risk. And you want to manage that airway and get it safe before you worry too much about what the particular diagnosis is. So what does that involve? Obviously, in an adult, you can have a look with a flexible nase endoscope to have a look how narrow the airway is, get senior help early, so ENT and anesthetics. And if patient's really struggling, maneuvers such as the jaw thrust, the head extension, simple airways, oxygen, intravenous steroids, and adrenaline nebulizers, and informed theatre, so you can get the patient to theatre for a more definitive intervention, which usually is intubation or a surgical airway, such as an emergency tracheostomy. That's probably all you need to know at this stage. Now, different things cause airway obstruction in adults and children. In children, we don't see much epiglottitis anymore because of vaccination programs, but foreign bodies are probably the most common cause, and then congenital abnormalities. That's the sort of the cause of airway obstruction that lead to significant danger. In adults, upper airway malignancies, bilateral vocal cord palsies, trauma and foreign bodies. Those are the sorts of things that cause airway obstruction. Good. I'm keeping half an eye on the chat. Yeah, I keep saying theatre. Sorry, that is just what we call it in the UK, but it's the OR as you would know in the US. Okay, so why would you need to do a tracheostomy? There are 4 main reasons. One is because the upper airway is obstructed, so you need to put a tube in here to let air go in and out. And so there might be obstruction at various different levels. Or if you are anticipating airway obstruction, so let's imagine that a patient has got a malignancy here and they're going to have radiotherapy, which might end up swelling things more. That might be a reason to do a tracheostomy. Also, if you know that a patient's going to be ventilated for a long period of time, so the patient that's been intubated and is on intensive care, you want to wake them up, but they're not ready to hold their own airway open, then you might before you take the tube out, you might do a tracheostomy for that reason. And also bronchial toilet. So if the patient's going to need a lot of suctioning, then that's another reason for a tracheostomy. Okay, I think that's kind of enough academia for one evening. Well, it's evening here. It's probably not evening where you are, but I hope that's been helpful. I thought you'd probably appreciate talking a little bit about careers. So I can tell you why I went into ENT. It's not a subject that is covered very much at medical school. And because of that, a lot of people discover it quite late. And if you have a placement that is 1 or 2 weeks, then it's very difficult to get inspired to do any specialty on that basis. But ENT is not all snot and wax. It's actually one of medicine's best hidden careers, I would say. The reasons I chose it are that we look after a whole age range of patients from newborn babies up until patients over the age of 100. So for me personally, I do cochlear implant surgery for babies born deaf, and if we do that early enough, we give them the chance to learn open set verbal language if we do that before they reach a certain age. So that's a really precious thing. And also being able to do that for patient in their 90s who has lost their hearing and become socially isolated. So a whole range of ages. And because we look after children, I think it tends to attract surgeons who are quite personable and quite good with people. And when you have a specialty that has people like that, it tends to attract more people like that. So that's definitely true of ENT. It's a wide variety of cases. So ear, nose, and throat means every day is different. Every year of your training is different. We use lots of gadgets. As you can see in my presentation, a lot of the emergencies are things that you can deal with as a junior and get people better and on their way without having to bring them into hospital for a long time. Some of the surgery is very challenging. Obviously, I'm operating in a 1 centimeter space and making holes in the stapes footplate that are less than 1 millimeter. So you're always being challenged. But restoring the senses has a real emotional impact on patients, and because of that, you have a big part in people's lives, and that is a big thing. I think whatever you choose, I know you're all students. Whatever career path you choose, I would say look at the seniors. I said earlier the term consultant is used in this country for attendings, but it's very easy to be inspired by high octane specialty or very keen junior. But actually, it's the senior post that you're going to be doing for 30 odd years. So that's probably the example you want to be following when you want to think, what do I want my life to look like? So those are my reasons. I've got a video, I've got an IGTV video explaining all that on my Instagram, and I stick lots of kind of TikTok-y type educational things on there as well. So feel free to have a look. Good, okay. Erin and Isis asked me to put a quote in. So this is kind of what I've said. The medical career is long and stressful and hard, and it can be so easy to lose sight of why you went into it at various stages. But I would say above all else, never lose sight of being kind to your colleagues and other hospital staff, whichever grade they are, from the most important person to the most junior grade of cleaning staff, and be compassionate to your patients and go the extra mile for them and maintain a service-focused attitude. I think that's after all why we are doctors, isn't it? And if you focus on that rather than being too preoccupied with your rank and grade and who you need to impress next, I've generally found that the best of my trainees tend to fall, who display those qualities, tend to fall in the way of the best advice and the most successful CV boosting projects naturally. So that would be my advice. Certainly that's the advice I give to my trainees in the UK who want to go into ENT, which is a competitive specialty. Good, okay. I've got a couple of books out there which are kind of mainly geared at British trainees, but equally kind of educational for anyone interested in ENT. So do check them out. They're on Amazon UK, probably available on your version of Amazon as well. Like I said, I am an ENT surgeon specializing in ear and hearing surgery. I'm based at the Royal National ENT Hospital in London. I think that's it from me. I'm happy to stay on and answer questions. So I'll let Erin and Isis kind of filter them and put them in the chat or verbally. And let me look at the chat box now. So, does a deviated septum always require corrective surgery? The answer is no. But you'll be surprised how many people offer it. It's got to be tailored to symptoms. So deviated if you take 100 people off the street and who don't complain of anything and look at their septums, many will be deviated. So you only want to correct septums that are causing unilateral nasal obstruction, or where you need to access the back, further back to perform some other kind of surgery. Do tracheostomies leave bad scars or damage? They can do. And in the late stages, once a patient is fully recovered, you might consider scar revision if that is something that they would like to do. You can a proportion of patients also end up with a fistula, so a permanent passage between skin and trachea. Again, those can be excised with further surgery. What is the craziest thing you've found in either the ear, nose, or the throat? So goodness, I told you the button battery story, but I remember there was a guy, I mean, most of these foreign bodies are in children, but I once had a guy in his 20s who was the partner of one of our nurses who sheepishly came in with a Tic Tac in his ear, a sort of minty thing in his ear. And basically he fell asleep 3 days earlier and his friends put it in his ear as a joke. And 3 days later they were like, did you not find the sweet in your ear? And he was like, what sweet? And he was wondering why he couldn't hear for 3 days. But anyway, so I pulled that out of his ear. It's that and spiders, actually. So one of my colleagues had a spider in his ear and I pulled that out. Good. Which countries can you practice medicine with British education? Well, anywhere really. Different countries have different exams to pass to practice as a doctor. So for instance, if I was, to practice in America, obviously you've got the USMLE. In the UK, we've got PLAB. Every country will have exams to pass in order to get a license, but generally the skills skills any doctor learns, they're portable across the world. So yeah. What are your hours like? So they're right. Now that I'm in a senior position, it's fairly civilized because my out of hours commitment is largely advice based. So 1 week in 12, I'll be on call for that whole week as the senior for our Central London department, but I've got 2 tiers below me. So generally, they'll call me if someone needs a very complicated operation, or they're just not sure, or they or they want some general advice. So my normal hours are probably 8 a.m. till 5 p.m. I might do 1 evening a week, and I have a couple of half days for private work. So in the UK, our health service is largely public funded. So I'm primarily a National Health Service public funded surgeon, but I have time for private work as well. Good. Any more questions? I'll have a look through the chat. Would I return to talk about auditory implants? Yeah, happy to do that. And there's more stuff on auditory implants on my Insta, so do have a look. Most common frequent procedures. Again, all that stuff's on my website, so have a look at that. Do I know British Sign Language? I don't, but I would love to. And actually, that would be a really useful thing to have learned, because lots of my patients use BSL, British Sign Language, and you have American Sign Language in the US. So if you have the chance to learn sign language at medical school, then do take the chance, because it's very valuable. Do you have to deal with infectious diseases? If so, how do you alter your? If so, how does that alter your typical work process? It depends. Obviously, we've been dealing with the C word, coronavirus, and obviously that's involved a lot of PPE and whatnot. But generally, yeah, I mean, the ear, nose, and throat is a reservoir for infection. So, I might operate on someone with mastoiditis. I might operate with someone with a neck abscess, or with a pus in their sinuses. Yeah, our role as surgeons is to drain those infections and work with our infectious diseases colleagues who will guide on antimicrobial therapy. Good. Any more questions? Or Erin and Isis, do you want to come back on, or do you want to keep typing questions?
We're sending the questions in the chat box if you want to answer them.
Lovely. Okay, cool. I'll keep an eye on the YouTube version as well.
Let us know whenever you're finished, though. No worries.
How are we doing for time? Okay, we're not yet an hour. I'm happy to answer any key questions. So training in the UK. Okay, I don't know if this is of interest, who this is of interest of, but medical school here is an undergraduate degree, so you can go in straight from leaving school at the age of 18. It's typically 5 or 6 years long, and then you would do foundation program, which is 2 years of very sort of junior level, rotating through different specialties. If you wanted to do surgery, then go into core surgical training, which is 2 years long, where you spend a lot of that time hopefully doing the specialty of your choice. And then you apply for ENT higher training, which is 6 years, At the end of that, you can apply for a senior position. If you want to, so I've ended up doing something quite niche in a central London hospital. Generally, you would do a fellowship in order to train to do that. So that's what I did. So I went to Cambridge to do a fellowship in ear and hearing restoration surgery. Do ENTs treat vertigo and VPPV? Yes, we do. So, and as an otologist, as an ear specialist, that is something that falls into my remit. So yes, treat dizziness, vertigo, and I would work with other specialists where needed in order to treat those conditions. Best advice you could give to your younger pre-med self? Well, I think I put the quote on the previous slide. I think that's relevant. I guess I didn't really prepare myself for how much your friendships change over the years of a medical career, because you move around and you get very close to the people you're working with, and then you rotate to a new job so many times. In the UK, we might do 3 different jobs per year in the junior stages. And even if you are very good at staying in touch with your friends, everyone else is rotating. So I think the natural part of the medical career is that you end up having to figure out who remain your long-term friends. So, and everyone else you might keep in touch with and see less frequently. How has COVID affected your work? So very much so. Obviously, I work in central London. We've had lots of COVID cases. Our planned elective service came to a standstill for a good 2 or 3 months. I was redeployed to the intensive care unit and started helping our intensive care doctors with stuff and doing the tracheostomies. And now we're recovering. So we're, for the last sort of 3 or 4 months, we've been operating again. The clinic is socially distanced, so it's moving more slowly, and that recovery continues. So it's a difficult time. Have you found there is a difference in quality of care or accessibility to care between private and public funded institutions? So that's a really good question. I think generally emergency care in the UK is done very well in the NHS and in big cities where private hospitals provide emergency services. But in smaller towns, private hospitals usually wouldn't provide emergency care. So, and then in terms of more planned care, again, it very much depends. So by going privately, you're guaranteeing being treated by a consultant, so the top level. But it's important that a patient finds out exactly, what that person is super specialized in. And I think by going to a super specialized trained professional, will they get the top quality care? So if that doesn't happen, then, arguably you may not get equivalent care to the public sector. But, in the UK, the National Health Service, has its difficulties with waiting times, but in terms of quality of care and international standards, it's right up there, because it's such a dominant part of our society here. I hope that answers that question. Training path, I've kind of answered. Again, there is I've got some posts on my Instagram about that, so check that out. Do you ever come across empty nose syndrome cases prior to specializing in auditory surgery? Yeah, so obviously during my regular ENT training, I had to train in nose and throat surgery, and over aggressive nasal surgery can lead to empty nose syndrome. It's pretty unusual because most people are aware of it. Essentially, for those of you who don't know, if you are too aggressive with removing the intranasal content, so the turbinates, what can happen is the patient can lose their sensation of airflow through the nose and feel permanently like they've got a blocked nose, even though they've got not a very blocked nose. So that's what empty nose syndrome is. So a good nasal surgeon will be careful about what they remove and what they leave behind. What are your opinions on the American healthcare system? Wow. Okay. So I have actually, I made a visit to my colleagues at the Mass Eye and Ear a couple of years ago. There are lots of similarities in terms of like how we manage things and the quality of care. I think standards are very similar. We obviously share a lot of ideas. Perhaps where it differs is billing and that side of things. In the National Health Service in the UK, I really don't have to think about billing on a patient by patient basis. Obviously, I have to think broadly about service delivery and costs, but essentially I'm liberated to generally do what's best for the patient. Beyond that, I'm probably not best placed to say about whether private healthcare is a good thing for everyone, because it kind of depends on how well the insurance policies are covering the entire population. And if the beauty of national health in the UK is that it's free at the point of access for everyone, regardless of what you earn. And I think that means that everyone has equitable access to good treatment when they need it the most. And I think that is good. And we all, as doctors, believe in that here. Good. Any more questions? Let me see. If a child fractures their nose and doesn't get it set back in time, what are the next steps? Is it the same for adults? Yeah, so generally you don't see nasal bone fractures in very young children, because the bone doesn't actually make a big portion, part of their nose. But yeah, if you miss the boat to do a manipulation, then the next option is a septorhinoplasty, which is a more sort of classical nose job, so to speak, involving breaking the bones and a cast on the nose and a very blocked nose for several weeks. So yeah. How do cotton buds and Q-tips affect the ear? Don't put them in your ear. That's the answer. Anything smaller than your elbow shouldn't go in your ear. That's what we always say. Cotton buds cause problems. They cause wax buildup. They cause perforations. It's not a good way of clearing wax. Tell your friends. Good. I think we've hit an hour. So I may not have answered all the questions, but feel free to ping me any questions on Instagram, and I will try and answer them for you. But I think an hour is probably all you probably want to handle. So I hope that's been interesting.
Thank you so much, Dr. Manjaly. It was such an honor to have you today. We had so much fun learning. Everyone, make sure you check him out on his socials. His Instagram is Ear Surgeon Joe.
Additionally, thank you all so much for attending. The link to the Google form has been posted in the comments as well as in our Instagram bio. So please remember to fill it out within the next 30 minutes if you want us to receive verification of your attendance. Additionally, we changed it today, so today's form will release the scores immediately, and we will be trying this out to see how it works. So hopefully it goes well and you don't have to wait to receive your scores, but if they're, we notice people are sharing answers and stuff, we might have to go back to waiting days. So just please be mindful and respectful. Thank you.
We hope to see you all at our next session tomorrow. Thank you again so much, Dr. Manjaly.